thank you very much for the kind introduction. And let me start by saying what an honor it is for me to be here under the auspices of the Taub Center. You guys are internationally renowned for work that is both rigorous and relevant, which is very hard to do, and you do it splendidly. So it's a real honor to be here. Now, this topic about provider responsibility, in the old days, it used to be easy to talk about this, really. In the old days, the provider was essentially the physician, and the physician was kind of a liberal, professional, entrepreneurial type whose duty it was to give good care to patients who reciprocally owed him or her, mostly him in those days, but him or her, owed deference, compliance, gratitude, respect, and not least important, money. And this was the great age of what we came to call professional sovereignty and provider dominance and all that sort of thing. But then, particularly in the second half of the 20th century, most Western nations went ahead and did national health insurance, not except, of course, for my native land, the U.S. Now, the physician, in many respects, retained those features, a liberal, professional, entrepreneurial type, but in a very different context now. And physicians in virtually all the countries that I'm acquainted with fought national health insurance. They didn't like the idea. My students in the U.S., they say, oh, well, that's just America. Every place else, the physicians were on board from the get-go, which wasn't really true. They fought national health insurance, but in nations other than the United States, the countervailing power of the left, democratic socialist forces, labor forces, agrarian populist forces, and the like, were too strong, and national health insurance won enactment. So then, everybody's covered with a new governmental framework. And doctors basically had to participate in the new system, or they would go out of business. They'd lose their patients. Out of this, there emerged a kind of social contract, a kind of reciprocal understanding, set of arrangements that providers would accept government involvement in setting prices, and they would bargain over that process. They'd sit and bargain directly with government in the case of a beverage-type system, or with sickness funds in the case of a Bismarck-type system. Their obligation, their right and their obligation was to bargain collectively, mainly over prices, and the government would be on the other side of the table. Part of the bargain, cost is price times volume, so government concerned about the cost of universal coverage deferred to the providers by saying, well, your role is to bargain over price with us or with delegates of ours, and we'll leave you alone with respect to volume. We won't engage in managed care, we won't have closed panels, we won't have selective contracting. You're all in on a more or less equal basis, as are all the citizens. And that social contract between providers and the state endured, this is a somewhat arbitrary figure, but just say, for the sake of argument, from the end of the Second World War down to about 1995, a good 50-year run in which this was, if not, maybe consensual might be too strong a word, but well established and accepted. Now, over the last 20 years or so, though, there have arisen challenges to this sense of the social contract between the state and the providers. And what I want to do today is three things. One is sketch these challenges, these broad contextual challenges, if you will, to that social contract. Secondly, talk a bit about what the way in which coping with those challenges is revising the sense of a social contract, or putting in play the search for a new kind of social contract in Western societies today. And then third, and briefly, some barriers to defining a new, if you will, responsibility agenda for providers. That sounds so pretentious. I'm going to sketch a responsibility agenda like I was a visionary thought leader or something, which I'm certainly not. But let's just accept the locution responsibility agenda and go with it. Okay, first of all, then, what are these challenges that set into the social contract that I just sketched? Well, from 1945 till the mid-70s, you had in most societies, what the French came to call the 30 Glorieuses, the 30 glorious years in which unemployment was low, economies were growing pretty steadily, people were doing okay. And in the context of steady economic growth, the also steady growth of healthcare spending wasn't that big of a deal or that big of a problem. In the ensuing years, after the mid-70s and down to the present day, you had, first of all, the cost became a salient issue. It wasn't unsalient before, but it became quite salient starting really in the middle and late 70s. And policymakers began to conclude that the kind of structured bargaining over prices that was part of the social contract, that was insufficient. And there arose a new interest in incentives in this sense that, well, consumers don't care about the price of care, providers don't care about the price of care, nobody really cares about the price of care except us who have to pay the bill, us budget makers in the public sector. There must be another way of going at that. Maybe we have been too indulgent with respect to our approaches to setting prices, and maybe we should be more innovative in our price setting or in our ideas. And maybe we've been too indulgent in leaving volume exempt from clinical micromanagement. Maybe there's a lot of waste out there on the volume side, and maybe we're throwing good money after bad. Maybe we should be looking more at that, resulting in less deference to providers with respect to costs, and the challenge to come up with new arrangements that would squeeze the cost of health care more aggressively. So cost is the first element of the challenges. The second is knowledge, which is sometimes not given its due in discussions of this topic, but it's very important because in the last 20, 25 years, you've had an explosion of knowledge of all sorts and descriptions: clinical research, epidemiological research, health services research, econometric research, some of which led to new answers about the functioning and malfunctioning of the healthcare system, but most of which led to really corrosive questions and put providers increasingly on the defensive. Just to give one quick example, the work that John Wenberg famously did, small area analyses that established all these practice variations that could not be plausibly explained on demographic grounds, on clinical grounds, on socioeconomic grounds, on who knows. To this day, there's still debate over how you explain them, but they're out there, and it looked like we were throwing throwing money away on arbitrary practice variations that were not professionally justified. And over time, more and more players in the system had access to this, to the information resulting from these studies, and could ask these questions. And that means payers and regulators and the public, particularly with the diffusion of information technology and the internet, it became possible for people to sit at their computers, just like the computer right here, and go and look at the alleged quality rankings and, you know, mortality statistics and all the complication rates of institutions in their community, the Dartmouth Atlas and all that sort of thing. This just deluge of information, some of it useful, some of it mischievous, some of it you know, have different implications. But if you look at the U.S. and I think elsewhere, you come to a remarkable point where policymakers are basically saying, you know what, this view of quality as a black box that only the providers can understand and operate within, that's not true anymore. We know how to define quality now. We know how to measure it. We know how to monitor it. We know how to regulate it. And we know how to calibrate payments to providers in such a way that we can steer the system toward better quality and away from inferior quality. You see this, the so-called quality solution, you see this at work in the United States in the aftermath of the Affordable Care Act. And it's based partly on this mountainous accumulation of knowledge and information, partly also on confidence and legitimacy, this new sense that providers don't have to be running the show with respect to quality. We can take that over from them. So there's less deference to providers with respect to quality, and the old argument, you mess with us and our practice arrangements and pay us too little, and you're going to destroy the quality of care in your healthcare system, it doesn't have the force that it formerly did. And the third broad and contextual challenge, I think, is generational change, which also is often underrated in these sorts of discussions because, you know, academics are studying what they have to study, which is what went on in the recent past, and you're trying to figure out why it came out the way it did. And even as the ink is drying on the paper, of course, generational change is contriving to invalidate or at least to qualify what it is that you figured out so scientifically. But this happens, and in this case, and it was discussed on the previous panel, the rise of consumerism, growing distaste for bureaucracy, declining percentages of public opinion poll respondents who said you could trust the state to do the right thing all or most of the time, which in the United States now are at historic lows or near historic lows, the aversion to command and control regulation and all of that stuff, the aversion to one-size-fits-all systems of coverage, and the interest in choice. If there's one word that kind of summarizes this flow of thought, it's choice. It's not enough just to be able to choose your provider within a broad system of universal coverage. No, you got to have choices of coverage as well as provider, and competition and incentives. And the notion that doctors, along with other professionals, teachers are actually a very good example, are monopoly suppliers who have been wrongly exempted from the bracing challenges of market forces and ought to be subjected to market forces. So you get a rising interest in managed competition, as here in Israel, in the Netherlands, in Switzerland. We're rising interest in it in the United States, but we declined it basically under the Clinton plan. But meanwhile, while we were turning down the proposals for managed competition in the U.S., you here, we're putting a system of that sort in place in Israel, and have persisted with it, and it's very instructive. And the notion that the way in which the citizenry accesses the healthcare system ought to be more managed, and therefore less deference to providers with respect to access, as well as quality, as well as cost. Okay, those are the three broad challenges. Contextual challenges. So today, providers find themselves more and more contextualized, if you will, by regulatory mechanisms, market mechanisms, institutional environments in which they practice. And that context, I think, sets up the discussion. The second point I want to talk about, what the so-called responsibility agenda for providers today. Now, as David and I have often commented, there's nothing much new under the sun in these discussions about healthcare policy. So I think the challenges to provider responsibility are new, but new in quotes, in the sense that we're talking about variations on persisting themes. But the variations are very important and very challenging. So what are the responsibilities? What is an agenda for responsibility of providers in these myriad and contemporary contexts that I've been sketching? Okay, here's my list, and then we can discuss it and see. What time did I start, and how much time do I have left? Okay, I'm okay. About 20 minutes left? Good. 12 minutes. Okay, that's about do it. All right. Yeah, I've used 18 minutes already? Oh, golly, I better speed up. Okay. Okay. Okay, first, patient safety and medical error reduction. I would surmise that hospitals in Israel, in the U.S., and physicians' offices are probably safer today than they have ever been in history before, which is very good news. But there's another side to it, which we have so much more information about the medical errors and risks to patient safety that are out there that it's a very pressing issue, very well documented. So there's a whole set of issues. Hand washing. You know, you raise that in a conference of learned health professionals. Why can't providers learn to wash their hands regularly after seeing patients? And people say, brother, that is pretty basic, isn't it? But hand wash is a real issue. patient falls, intravenous infections, drug reactions, long list of things which we now understand are much more frequent than anybody thinks is acceptable, and means that we have to come to reckon with things that are fairly straightforward, like checklists that go on, Atul Gawande and others have promoted. And also we have to deal somehow, providers have to deal with what Charles Bosk, the great sociologist, I think called, probably was he that termed the normalization of error. You know, okay, yeah, I know you made a mistake, but you know, that can happen to anybody. Let's not talk about it. You'll do better next time. How do you do that? I have sat at conferences, as a kind of guest, when quite high up officials at a New York academic medical center sat around and discussed how do we actually get our providers, and not just the physicians, but the nurses and other personnel, reliably to wash their hands between contacts with patients. And you mentioned, I think, Leora, the behavioral economics. Shouldn't we be bringing in could we bring in behavioral economists to figure out creative ways to get people to wash their hands? It's harder than it sounds. But the patient safety and medical error reduction agenda is important. The second has to do with evidence-based medicine, and how do you deploy it? As I say, we've come to be awash in knowledge. And sometimes the random controlled trial or the other kinds of rigorous experiments and demonstrations will give you the answer to the problem you're seeking, but just as often, they'll unsettle conventional knowledge that you have been walking around with and practicing, or leave you in doubt, and one day's findings under evidence-based medicine will be confounded or refuted by the next day's studies, and so it goes. So you get this odd mix of new areas of certainty and also new and large areas of new uncertainty about what really works and what is truly in the patient's interest. Now, somehow you want providers that won't just reject it out of hand. I can remember years ago, Arnold Relman, the professor of medicine at Harvard, who was the editor of the New England Journal of Medicine. He'd go and give talks on this and a bunch of other things. And he's, evidence-based medicine. I went to medical school. They go to medical school. What do they learn in medical school? Isn't that evidence-based medicine? What are you talking about? What's new about that? Well, you don't want out-of-hand rejection. You also don't want a slavish deference to the algorithms or today's findings of evidence-based medicine. Somehow we have to figure out ways for providers to cope with this in a dynamic fashion that takes advantage of what evidence-based medicine has to offer, but doesn't substitute for professional judgment. That's a second agenda item. The third is very familiar: integration. Improving handoffs, consultation, coordination, changing the structures of medical care. And here we had good discussion in the previous panel about the demands of chronic care patients. What do you do in a society where people live to be 90 years old with increasing numbers of chronic conditions that they've begun to acquire and suffer from in their 40s and 50s? And what they need is not only and not mainly necessarily clinical care of the usual sort, but you need a continuum of care which involves reorganizing the caregiving process around a whole range of professional skills, which includes physicians, both generalists and specialists, but also nurses, nurse practitioners, nutritionists, dietitians, discharge planners, social workers, clergy in some cases, physical therapists, mental health providers, a whole range of things. And we have to, providers nowadays need to be creative about how you organize that continuum of care. And it's not, there's a lot of discussion about it, but it's not clear how you do it. And then you still have Kaiser Permanente out there as the kind of holy grail, the ultimate integrated system. Is that where we really want to go? There's still, after all these years, plenty of people out there say that's the only way to do it right. Is there one right way? And if Kaiser isn't the one right way, what are the alternatives that are more realistic or practical? That's a third item. Fourth is patient-centeredness. Very, very important. The patient as partner. Good discussion in the previous panel of that also. My sense is we've developed the rhetoric of patient-centeredness a lot more than we've developed the reality of it. And it's still very much a work in progress. And to the points about, that's where I think prevention and health promotion really fit in, you know. In an age where, at least in the US, physicians are more and more scheduled for 15 minutes, 20 minutes per patient visit. And as was pointed out, they're looking at their computer and the patient's over there and they're occasionally glancing over. How do you build trust? I don't remember hearing the word trust arising in our discussion so far this morning, but it's absolutely crucial. And if you're talking about patient-centeredness, that's what you have to talk about, the building of a trusting relationship which permits ease of communication back and forth between patient and provider. That's the kind of partnership that really counts. And that's where I think prevention and promotion fit in, because if you're going to encourage people, you're going to talk to people about their smoking, their substance abuse or consumption of alcohol or other substances besides their dietary patterns, which are often very sensitive to people, and their exercise habits, and et cetera, that patient-centeredness, that communication, that trust, that back and forth, that reciprocity is absolutely crucial. And I wonder if we're not, you know, talking in one direction about patient-centeredness, but in practice going in the other direction about making it harder to build those kind of relationships that make the patient a genuine partner in these kinds of decisions. Very, very important. Fifth on this agenda would be naysaying. Came up in a fascinating way here about the scope and limits of solidarity and incentives versus penalties and the like. I think it's crucial providers are beginning to see that you're dealing with scarce social resources. It's not all, the healthcare is not indeed free. And providers have to get beyond a self-protective stance here. There are areas where nurse practitioners might do a better job of caring for the population than physicians do at lower cost. Exhibit A is this from the Taub Center. There are twice as many nurses in the OECD as in Israel. There are challenges here about how you do this. And you're coming with the sign to tell me I have only a certain number of minutes, right? Okay, I'll try to get a move on here. So, I mean, that's important. Physicians, and they're probably not taught this. The picture of the medical school classes, they learned about cost effectiveness analysis, comparative effectiveness, research, all that sort of thing. Extremely important. And it may not be as important in the Israeli context, but it is in the United States where, you know, the entrepreneurial, profit-making, income-maximizing imperative seems to suffuse just about everything in the American system. We, at least, and possibly providers and other systems too, have to learn to rein that in somehow in the interest of solidarity, to be sure. Moving along on this list, sixth is addressing inequalities and disparities. Wasn't that long ago where the idea was, look, you do national health insurance, you've got universal coverage, everybody's got universal access, case solved. That's the victory for equality and equity that you want. Well, we've come to realize it's not that simple, that you could have equal access and equal entitlements and still very different outcomes and very different patterns of access to the system, and oftentimes allegedly universal access isn't really universal either. In the U.S., we face this issue of stigma. We got 21 of our American states that won't expand Medicaid with free federal dollars, partly because they just don't like Medicaid. And we got physicians in the United States who will take a certain number of Medicaid patients, but they don't want too many. Not just because those patients are paid for by the government less, because they don't want too many of those Medicaid types sitting in their waiting rooms with their middle-class patients. It spoils the ambiance, as it were. And you deal with this, and there are disadvantaged populations. There are undesirable populations. Stigma is a reality. Whether we should be, as it were, stigmatizing, penalizing, incentivizing smokers, these are very big issues, and they need to be dealt with. And they keep popping up. I had a very interesting discussion with some medical students at Mount Sinai just last week. Value-based purchasing. You're paid according to the value of the services that you render. Does that give you an incentive to select preferred risks? That is, if you've got a very complex, difficult case, and you're going to require a lot of resources, and you're only going to get paid so much. Do you want to shunt those, send those people elsewhere, subtly or not so subtly, not take care of them after all? There are all kinds of issues of this sort, very important, and they pop up. There's ripple effects to these payment reforms that have to be dealt with. And seventh and last on the list, and it's come up gratifyingly all the time in the previous discussion, social determinants. This is the argument that health status of populations and individuals depends on a lot of things that have little or nothing to do with healthcare per se. And if your objective as a healthcare provider is to improve people's health, maximize the health of populations, improve health of individuals, you may have to attend to things that are not clinical. And there's a long list of social determinants that are discussed in the literature. Income distribution, relative and absolute. Housing conditions, education, most certainly. Stress, status, long list. And the theorists of social determinants don't agree on what are the ones to emphasize, but they are out there and they're very important. And I think it's a practical matter for providers, 3 minutes, okay. For providers, if you're not going to be able to change income distribution, but you may be able to think about the situation of your patient in the context of the housing they go back to. Do you try to deal with the supportive housing authorities, the transportation that they have, the protection, domestic violence was mentioned in a question. They go, what kind of environment are they going back to, and what are the social conditions that they're subject to that are going to shape their health, and how much and how providers can get involved in those sorts of things is very, very important. Okay, quickly in my remaining less than 3 minutes now. Okay, so I think this list arguably I think is what the raw materials for, if you will, a new social contract that providers need to think about in exchange for what is still a lot, all the talk about the waning of cultural authority and the decline of professional dominance. Yes, but there's still great prestige, respect, and income that providers still enjoy. And there's new terms of exchange, there's new reciprocities, there's the need for a new social contract. I want to close just by mentioning two barriers to achieving a new social contract. One is that I think reformers too often take a very one-dimensional view of providers. They're looked at as income maximizers, and incentives are the all-purpose lever, and too little attention is paid professionally, academically, and in policy circles to professional and organizational considerations. And David Chinitz here with Victor Rodwin wrote a really good piece on this that I recommend to you in the Journal of Health Politics, Policy, and Law. What, about a year ago, David? Or about a year ago. Very well dealt with there. I would give you a list of examples if there was time, but there isn't, just so quickly. I mean, in the United States with managed care, we looked at Kaiser Permanente and said, that's great, that's a great system. Let's try to achieve the same cost efficiencies and virtues of Kaiser Permanente by creating something called HMOs and managed care organizations. So 45 years later, we started basically doing this in 1970. So 45 years later, we have a managed care industry in which the organizations and the providers look basically nothing like Kaiser and behave basically nothing like Kaiser. We didn't think it through properly. Or just to give another a quick example, I recently had the pleasure of reviewing the 7th edition of Rudolph Klein's wonderful book, The Politics of the National Health Service in Britain. And, the National Health Service has reorganized itself umpteen different times over its 60-some years of existence. And every point along the way, including today, there's officials in the National Health Service and the Ministry of Health in England thinking, okay, we've set forth the terms of this organization. It's gone out there. Are the providers doing what we expect them to do? What are they doing out there in the real world? How do we know? How do we find out? What can we do about it? How can we motivate them? It's very complicated, and the incentives are not the all-purpose solution. So I borrow a term from a French friend, Jan Bourgoy, who's a doctor who heads a research organization in Paris and does research on the French system. He said in conversation that you need reforms that are soluble, ones that can penetrate the the professional and organizational context of medical practice and be assimilated, can dissolve into them in a beneficial way. Well, if they're too soluble, they're not going to make any difference. If they're insoluble, they're not going to help. There's a fine art to trying to figure out what are soluble solutions, but it takes dialogue. It takes, what did Jay say? The discourse brings clarity, and you need a broader and better discourse with the professions. But on the other side, and I probably used up all my time, but I'm coming very quickly to the end here. On the other side, you've got problems of professional representation in policymaking. When I was thinking through this talk, there popped into my head, you know, Robert Michels, the great sociologist, the iron law of oligarchy. It occurred to me, it's not that, it's more like the iron law of introversion. And I'll just give you an example from the US case about how professions get represented to policymakers. Okay, time's up. Okay, I'll just give you one more minute. Or I'll stop short. Or I won't give you an example of the US case. I'll do it very quickly. Okay, so who speaks for the, you know, look at the hierarchy of the AMA and the professional societies. Who are these people? Well, they're a doctor, male or female, practicing in a community, gets mad about something. Government's taking too long to pay. Government's doing something wrong. Or the commercial insurers or the managed care organizations are pushing us around. You get mad about that. You get involved in the local medical society, county medical society. Begin to specialize in pushing their issues politically. Get into the state medical society, the AMA, House of Delegates, and by the time you look at the profile of people that are there in the hierarchy, the highest levels of medical representation, they're reactive, defensive, introverted, and not particularly, they're interested only in a dialogue to the extent that it advances what they want to have said. I don't know if that's true in Israeli medical politics, but it's something to think about. I think it was Edmund Burke wrote that in politics, and I think in policy, magnanimity is not seldom the truest wisdom, and we need more of that from our professional representatives. And the way you get that, I think, is by acknowledging ultimately, you know, what Weber called the ethic of responsibility, which you have very nicely pinpointed in your framing of this conference, and that entails acknowledgement that when you get right down to it, the healthcare is a humanistic pursuit. It's a social enterprise. It's a democratic construct, and it's an ethic of responsibility that providers need to work on in dialogue, reciprocally, in a social contract with policymakers, if those things are going to flourish. So thank you, and sorry about the running over.